Hello and welcome to the Project iCare podcast. This is a recording for healthcare providers who want to learn more about improving care for patients with substance use issues and addictions. I'm your host, Dr. Kasey Claborn, a clinical psychologist and research scientist at the University of Texas Dell Medical School.
And my name is Sydney. I will help narrate this podcast by defining terms, explaining concepts, and citing statistics that are relevant to the topic.
Have you ever wondered about HIV treatment, what antiretroviral therapy is, and how it affects viral load, or if there will ever be a cure for HIV? Well, that is exactly what we were talking about on today's podcast. Today I'm podcasting from Austin, Texas with Dr. Parker Hudson. Dr. Hudson is an assistant professor of internal medicine and infectious disease at Dell Medical School. Welcome, Dr. Hudson.
Thank you for having me.
All right, so we're here today talking about HIV treatment, and you are currently an expert in that area. Why don't you tell us a little bit about your background and history working with patients with HIV?
HIV, most importantly, one of the things that I love to treat and a patient population that I love to care for. I trained in internal medicine and general pediatrics and had exposure to patients with HIV even before my medical training. It was one of my primary reasons I went into medicine. And subsequently, I did an adult infectious disease fellowship, and now I take care of people with HIV both in the hospital but also in a community clinic here in Austin, Texas.
According to the CDC, in 2015, 63% of people living with HIV received some HIV medical care. To locate an HIV healthcare provider, you can search the American Academy of HIV Medicine's referral link directory or call your state's HIV/AIDS hotline. These and additional links are provided in this description box below.
So one thing I hear all the time is that we found a cure for HIV, that HIV is curable. You know, you see some news snippets and stuff about this every once in a while. Is HIV curable?
So the short answer is no. I spend a lot of time talking to my patients about this, especially during the first few visits, and that is HIV is very treatable, just not curable yet. And everybody wants to know when the cure is coming. I'm also eager to know that. And my assessment of the current research is that we're at least 10 years away. And So what I would say is we have fantastic treatment, and our goal as a medical community is to try to maximize the benefits of that treatment and make it last for a lifetime at this point, because it may be the cure is at least a decade away or may not be possible.
Okay, that makes sense. So you think HIV isn't quite curable yet, but you said it's treatable. So I know HIV has evolved as far as the treatment goes over the last 20 years quite a bit. Tell us what HIV currently looks like as far as treatment goes.
Absolutely. So the good news for people who have been recently diagnosed with HIV is that for the most part, people can take one pill and take it once a day, and it will fully suppress their HIV virus and allow them to live a life expectancy that approximates the general population of people living without HIV.
It is recommended that all people living with HIV get treatment. There is a misconception that HIV physicians wait until a patient's CD4 count is low or less than a certain number, but this is false. In fact, we know that all people living with HIV infection have better health outcomes on treatment regardless of CD4 count. Therefore, everyone with HIV should be on treatment. The CDC's National HIV Surveillance System and Medical Monitoring Project showed that in 2011, the life expectancy of a person diagnosed with HIV at age 20 and on current ART will have a life expectancy of 71 years. This is 8 years less than the average life expectancy of a person without HIV. For an individual that is diagnosed with HIV at age 20, not receiving HIV medication and not in care, their life expectancy is approximately 32 years.
So how has HIV treatment changed over the past 20 years? You know, it was 1996 when we first were introduced to antiretroviral regimens.
Right.
It seems like we've made lots of progress. Can you talk a little bit about that progress?
Yes.
Okay.
So the most important change to HIV treatment in the last 20 years is that all patients with HIV should be treated with HIV medication, antiretroviral therapy. Over the last 25 years, numerous studies have contributed to this body of knowledge that has completely changed the paradigm from waiting till people were sick with AIDS and a CD4 count less than 200, and then we raised the treatment level to 350 and then 500, and now the most important thing for all providers and patients to know is that everybody does better on HIV medicine. We used to weigh the risks and benefits of HIV medicines versus their side effects, but the meds are so much safer with less side effects, and the benefits are just so incredible. The two most important benefits are, one, the health and well-being of patients, people living with HIV, and two, that when people with HIV are treated, we know that they cannot transmit. So an undetectable viral load means that their virus is untransmissible, and that's great for their sexual life and their partners, and that's also great from a public health perspective because then new infections do not occur. The other part of the paradigm change has not just been that all patients should be treated for HIV, but in general, we look at that as being off medication as really an emergency, and we like to treat people as soon as possible, ideally even within a day or two of being diagnosed with HIV. Interestingly, actually, the treatments in some ways are fundamentally the same. And so HIV treatment is still considered 3 drugs, 2 of which are from one class of medicine called the NRTIs, nucleoside reverse transcriptase inhibitors, and one from a second class of medicine. One major way that treatment has changed is that the original medicines were 2 NRTIs plus a protease inhibitor. And now all of the first-line regimens are integrase inhibitor based, paired with 2 NRTIs. And with that, they are more potent, meaning they decrease your viral load faster within weeks versus over the course of a month or year. They're more durable in the sense that it's harder to get resistance to them, and they're safer with many, many less side effects, and now co-formulated to 1 pill once a day regimens.
That's great. So I hear the word viral load a lot. What exactly is viral load, and how do ARTs interact with viral load?
Yes. So your HIV viral load, which is the amount of HIV RNA, the amount of virus per basically drop of blood, is probably the most important lab that can be checked and followed for any person living with HIV, because it is the ultimate biomarker of effectiveness of their therapy, their adherence to the therapy, and ultimately their long-term clinical outcome. It does not tell us about the amount of HIV in other parts of your body, but what we do know is that if your viral load is undetectable in your blood, is that you cannot pass HIV on to anybody else, and you will not progress to develop AIDS, and you will have many, many, many less complications from having your chronic HIV infection. It's important for people to know that once your viral load is undetectable, that tells you the medicines are working, but that you have to maintain the medicines to keep that viral load down. What we do know is that when you stop medicines, your viral load will come back because you still have the HIV virus in your body. It's just fully treated and suppressed because of the medicine.
So does that mean that someone who has HIV can confidently have sex with someone who's HIV negative without a condom?
So this is one of the exciting areas that the research is very convincing. We have multiple public health agencies, including the CDC, highlighting the fact that U equals U. So undetectable viral load means that you are untransmissible of your HIV. And if you and your partner choose to have condomless sex, that you cannot transmit HIV. That's a discussion and a choice because condoms are very important for preventing many other types of infections, not just HIV, including syphilis, gonorrhea, and chlamydia, and some other sexually transmitted infections which have been on the rise lately. But from an HIV perspective, you cannot transmit.
Cool. That's really exciting.
It is very exciting and has been very empowering to our patient population. This has been an issue where there's ongoing sort of stigma and shame.
You know, I've had patients in the past that had really bad side effects from their medications, and then they stopped taking them. Can you talk about some of the side effects associated with ARTs?
Absolutely. Those are great questions and really important parts of HIV care. So part of the advances over the last 20 to 30 years of treatment is that the medicines have many less side effects. So the main side effects that we worry about with the integrase-based therapy is really what I talk about as this sort of upset stomach. Some people call it grumpy belly syndrome, where when you start the medicine for just 1 to 2 weeks usually, you know something's not quite right, a little queasy, a little nauseous, a little crampy, and your body gets used to it. And I've basically never had a patient who's had to stop the medicine. It's important to be able to sort of push through as your body adjusts to the medicine. There also can be side effects related to trouble sleeping, and some people have found effects on your mood, but these are very rare and are not a great cause of concern. The final side effect to counsel patients about is the possibility of weight gain, because it is often most important to them and to their body image, and most patients are bothered when they gain 10, 20, 25 pounds after they start HIV meds. It's impossible to predict who is going to go on to gain weight, and it does not seem to be associated with a specific type of HIV medication, and often it's a sign that their medication is actually working and overall they're becoming healthier, but the medications have been associated with increases in both visceral fat and truncal fat. The medicines in general do require some monitoring. It's important to know about other comorbidities people may have, if they have hep B infection, if they have kidney disease, other possible health problems, to know about how those could affect the medicines.
Okay, great. So tell me specifically, what is drug resistance and then how does it develop?
If you send an HIV viral load test on someone's blood, most commercial assays now show a viral load with a lower limit of detection of around 20 copies per ml of blood. And so that result, if it's less than 20, will be undetectable. These are newer assays, and a lot of the research and our understanding is really based on having a viral load of less than 200. And so from the CDC's point of view and the HIV guidelines point of view, less than 200 is referred to as undetectable in the setting of you cannot transmit and your therapy is working and you don't need to make any modifications to therapy. Being less than 50 or even less than 20 is in some ways ideal. Being between 50 and 200 is considered low-level viremia, which there's some controversy around, but the official position now is that that is still in the undetectable range, being less than 200. Now, so what happens if your viral load is over 200 on multiple checks, then you're experiencing virologic failure. And there are two main reasons for virologic failure, and that is poor adherence, meaning you're not taking the medicine enough to fully suppress the virus, which can also then be linked to resistance. And so what resistance is the HIV virus is a virus with a genetic code and is able to mutate. And so if the virus is replicating in the blood and there's drug levels that are present but not high enough to fully suppress the virus, then the virus is constantly mutating, and some of those mutations will actually adapt the virus to be resistant to the drugs. And so at that point, even if you take the medicine as prescribed every day, your medicines are likely to stop working.
Okay, so then our second line HIV treatment regimens, do they tend to be more difficult or challenging?
The good news today, again, one of the advances over 30 years, is that we have at least 7 classes of HIV medicines and many, many, many more options than in years past. But even with that, we like to preserve first-line therapy as long as possible because it's best and safest. There are plenty of other second-line options so that if people do develop resistance on first line, there are more treatment options and it is not a death sentence or a reason that someone should not be on HIV medicines.
Okay, that's great. So I do a lot of work with people who have both HIV and then also substance use disorders. So like heavy drinking or illicit drug use. As an HIV physician, how common do you see this in your clinical practice?
Very commonly. So in my specific practice, I would say somewhere between 20 and 50% of patients have a comorbidity.
According to a 2018 study, substance use disorders reduce HIV retention by 9%, independent of age group, clinic, and sex.
So Parker, when you have a patient with a comorbid substance use disorder, what issues around adherence to the HIV medication do you discuss? How do you counsel your patients about adherence?
I think the first thing to recognize, all patients are different, and some patients find a way, no matter what they're using or no matter where they are in life, to take their medicine every day. And it's important to say that there are many barriers to adherence, and mental health and substance abuse are certainly one of them, although having a mental health or substance use disorder is not a reason to withhold medicine out of fear of poor adherence. I talk to all my patients when it comes to adherence. First is education, because everybody's starting in a different place. So we talk about the virus, we talk about resistance, we talk about how adherence, and the goal is to take more than 90% of your doses of medicine, which if it's once a day is really missing less than 3 times a month, and the importance of why that is. Then I usually talk to them and ask them if they've ever taken a medicine every day and how they found that. So what's their prior experience with taking a medicine every day, and what insights they have about what the challenges were. So we try to work through those on an individual level, and then start to inquire about their current daily routine and habits, where they think taking a pill every day fits into that, and what would be easiest. And generally we try to link it with some habit like brushing your teeth or something that people do every day. There can be barriers to that if they are living in a place where other people don't know their status. They may be having to hide their meds and are worried about being outed by their medicines. So there are some other potential issues there. We talk about setting an alarm or downloading an app on your phone as a reminder, where you can get texts or alerts and you can actually track your medicine, because sometimes you may take it and you can't remember if you took it or not. And then finally, one of the major areas that I focus on that leads to poor adherence is actually when people have the medicine, they take it well, but it's the refill. So planning for how do you get your next bottle of medicine, making sure the pharmacy is alerted, making sure it's in stock, and you're able to pick it up before you run out. For me, in my experience, that's been one of the major areas where people end up missing 3 to 5 days to 7 days every month because they're just running out.
Yeah, so that problem solving and planning ahead is really important.
Exactly.
In a 2017 study, it was found that HIV patients that have comorbid conditions, suboptimal ART adherence, and/or detectable viral loads should be screened for an alcohol use disorder.
So one thing I hear a lot from patients, especially within the context of alcohol use, is that, well, I can't take my HIV meds because it interacts with my alcohol, and I've been told that it could be really bad on my liver. If I am a heavy drinker, I should probably not be taking my HIV meds. Is that true?
So the answer for most patients, depending on if they have underlying liver disease and what comorbidities they could have, but the answer for most patients is taking your HIV medicines every day is going to lead to better health than not. Even if you're drinking, even if you're using other substances, if you're able to take it, it's better to take it if you're taking it every day. Because otherwise, you're at risk of getting much sicker from potential rapid progression to AIDS and or having a complication of HIV infection.
Absolutely. So can you talk very briefly about what that progression to AIDS looks like? In the past, we heard about AIDS a lot. It seems like we never hear about it anymore.
Well, that's an interesting observation. And what it highlights is that HIV treatment is highly effective. So that if you take HIV medicines, ART, you will not develop AIDS. Now, for people who are having difficulty taking their meds or who are out of care or not on medicines, historically the teaching has been that it takes 8 to 10 years of chronic HIV infection to destroy your immune system to the point of reaching AIDS, as defined by a CD4 count less than 200, or one of the many clinical conditions like PCP pneumonia, PJP pneumonia, that qualifies you for having AIDS. What we've learned from the more recent studies is that, like in many things, there's a range. And 8 to 10 years is a nice number to have in your head. The problem is some people are rapid progressors. And within a year, even 6 months, especially if they have other comorbidities, maybe like substance use, they may rapidly progress off meds to having AIDS. And some people, rarely, are maybe non-progressors, and it may take 20 or 30 years off of meds. So 8 to 10 is a good ballpark, but for any individual that you're working with or counseling, you don't know if they could be sick or, diagnosed with AIDS-defining cancer or a severe infection like meningitis or pneumonia within 6 months of coming off medicines.
Wow.
According to the CDC, acquired immune deficiency syndrome, also known as AIDS, is the third stage of HIV and is characterized by a CD4 count below 200 cells per cubic millimeter of blood, or the acquisition of PCP or PJP pneumonia,
or one of the many clinical conditions that qualifies you for having AIDS.
Pneumocystis pneumonia is a fungal infection that occurs in patients with a weakened immune system and causes fever, coughing, chest pains, difficulty breathing, chills, and fatigue.
So is there a test to determine who's a rapid progressor and who's not?
There's not. It's following the HIV viral load again and the CD4 count, which is the best measure of the immune system's strength in the setting of chronic HIV infection.
Well, Parker, this has been really enlightening. Do you have anything else that you would like to add? Anything that you would like other clinicians to know?
One thing that is important when it comes to adherence is that people still feel shame and stigma around HIV and even having to take the meds. So one reason for poor adherence can be denial and or that feeling of stigma. And so talking to your patients about what's their social support and who they've talked to about their HIV and if they're supportive, so they're not, sort of hiding and alone, and asking them how they feel when they take their medicine, because it's a daily reminder. Some people feel it as almost like it's a scarlet letter that they're wearing every day as they open their pill bottle. And so trying to reframe that as when you open your pill bottle and you have to take that pill every day, that you're choosing to do that because you're choosing to live and you're choosing to live positively, and by taking this med you're going to live a long healthy life. So creating that positive association with taking meds rather than a negative association.
Yeah, that's a great reframe. I like that a lot. All right, well, thank you, Dr. Parker Hudson. I appreciate your time and all of your insights.
It was a pleasure.
This has been a Project iCare podcast with Dr. Kasey Claborn and special guest Dr. Parker Hudson. If you liked our show and would like to know more, check out our website at sites.utexas.edu/Health Innovation Lab, or find us on Facebook at UT Health Innovation Lab. Visit our website to find more about Dr. Parker Hudson and other resources discussed in this podcast episode. All the information will be linked in the description below. Thanks for listening.